Stroke or cerebrovascular accident. In a stroke, blood supply to the brain is affected. Brain is critically dependent on an uninterrupted supply of oxygenated blood. Brain constitutes about 2% of body weight, about 1.5 kg in an adult, and takes about 18% of the total blood volume in the body. Loss of consciousness occurs in less than 15 seconds after blood flow to the brain has stopped, and irreparable damage to the brain tissue occurs within 5 minutes. Cerebrovascular accident or cerebrovascular disease or stroke occurs as a result of vascular compromise or hemorrhage and is one of the most frequent sources of neurological disability. Abrupt onset of neurological deficit occurs due to the poor perfusion of a particular region of brain. There are different terms for stroke. Here I will discuss the hypertensive brain hemorrhage or hemorrhagic stroke or spontaneous intracerebral hematoma due to uncontrolled hypertension. Stroke is a common cause of neurological disability and death in elderly patients. Arterial thrombosis with occlusion of the cerebral arteries leading to infarct is the most common cause of stroke. Second commonest cause is the hemorrhage, that is hemorrhagic stroke. About 85% of the stroke are ischemic and 15% are hemorrhagic. Most common modifiable risk factors are hypertension, cigarette smoking, obesity, increased blood lipids, heavy alcohol consumption, poor control of diabetes mellitus, stress, etc. Common history is the missing dose of antihypertensive drug or poor drug compliance to the antihypertensive medication. TIA, that is transient ischemic attack, is a type of CVA, cerebrovascular accident. TIA is episode of focal neurological dysfunction as a result of ischemia which resolves completely within 24 hours. Symptoms may be loss of consciousness, weakness of limbs, visual symptoms, vertigo, deviation of face, difficulty in speaking, memory deficits, etc. TIA are important determinants of stroke. Around 30 to 50% of cases of stroke had previous transient ischemic attacks. As the name suggests, the symptoms are transient, are temporary, and gets resolved on its own within 24 hours. It is usually a warning sign and suggests that the person is very much prone to a full-fledged stroke and its sequelae like permanent neurological disability. I will focus on hemorrhagic stroke because most of the neurosurgeons deal with intracranial brain hemorrhage or intracranial hematoma. And as I told you earlier, that CVA or stroke is of two types: ischemic stroke, that is infarct, or hemorrhagic stroke, that is brain hemorrhage. About 15% of strokes are hemorrhagic, which is due to spontaneous intracerebral hematoma. Even the hemorrhagic strokes are of different types. My presentation is limited to hemorrhage due to hypertension. Hemorrhage most commonly results from rupture of the small penetrating arteries damaged by degenerative effects of chronic hypertension. In 1868, Charcot and Bouchard described the rupture of microaneurysms as the cause of intracranial hematoma. Most common cause of intracerebral hematoma in elderly is hypertensive bleed. As commonly seen in elderly that there is a unnoticed hypertension. Many elderly persons are either not aware about this condition or on irregular treatment of hypertension. Common site of hypertensive bleed is basal ganglia. In hypertensive spontaneous intracranial hematoma, the most common cause of spontaneous intracerebral hematoma in adults is a hypertensive atherosclerotic or arteriosclerotic basal ganglionic bleed. The median age of spontaneous intracerebral hemorrhage is about 56 years. The common clinical features are sudden onset severe headache, vomiting, slurring of speech, depressed level of consciousness, and weakness of face and limbs. Commonest cause of intracerebral hematoma is the long-standing hypertension, irregular antihypertensive medication, history of smoking and alcohol intake, diabetes, and lack of physical activity. Common sites of hypertensive brain hemorrhage are basal ganglia, pons, cerebellum, and cerebral cortex. Location basal ganglia, that is the lentiform nucleus, putamen globus pallidus about 50%, thalamus 15%, pons 10%, cerebellum 10%. Common arteries involved is lenticular striate branches of anterior and middle cerebral arteries. CT scan is the investigation of choice for diagnosis of hypertensive intracerebral hemorrhage. I have made this sketch diagram to show the cross section at the level of basal ganglia. This image shows the frontal horn of the lateral ventricles. Floor is formed by caudate nucleus, then globus pallidus and putamen, thalamus. In between two thalami there is a slit like third ventricle, a pineal gland, sylvian fissure, external capsule and internal capsule. This image is very important to understand the ganglionic hematomas. Basal ganglia is the commonest site of hypertensive bleed. Thalamus is the next common site of hypertensive intracerebral hematoma. This line diagram shows the common sites of hypertensive bleed, that is head of the caudate nucleus, putamen, globus pallidus, and thalamus. In basal ganglia and thalamic bleed, extra intraventricular extension may occur. This image is showing the diagram of the lateral ventricle, third ventricle, and fourth ventricle. The second picture shows parts of the midbrain, that is the crus cerebri, substantia nigra, tegmen, tegmentum, and tectum, and aqueduct of Sylvius. And the third lowermost image shows midbrain, pons, medulla oblongata, fourth ventricle, superior inferior canculi, and cerebellum. Basal ganglia consists of caudate nucleus, lentiform nucleus, that is globus pallidus and putamen, and substantia nigra. Thalamus is not part of basal ganglia, and two thalami lie just lateral to the third ventricle. This line diagram shows the coronal view of the brain, where you can appreciate the interhemispheric fissure, Sylvian fissure, insula, putamen, globus pallidus, thalamus, and subthalamic nucleus. Arterial supply of brain comprises of anterior circulation, that is 85%, and posterior circulation, that is 15%. Anterior circulation is contributed by internal carotid arteries, and posterior circulation is contributed by vertebral arteries. ICA is the branch of common carotid artery, and vertebral artery is the branch of subclavian artery. The vertebral arteries supply the brainstem, cerebellum, and parts of thalamus. A circle of arteries at the base of the brain is known as circle of Willis. It is named after the English neuroanatomist Sir Thomas Willis. It is found by two anterior cerebral arteries connected with each other anteriorly through anterior communicating artery. The two posterior communicating arteries are connected to the posterior cerebral arteries, which are the terminal branches of the basilar artery. This picture shows the major arteries supplying the brain. Here the circle of Willis is made, where internal carotid artery, when divides into two anterior cerebral arteries and middle cerebral arteries, these two anterior cerebral arteries are united with each other with anterior communicating artery, and then posterior communicating artery, which is a branch of internal carotid artery, it goes and unites with the terminal branch of the basilar artery, that is the posterior cerebral artery, forming the circle of Willis. The two vertebral arteries unite to form the basilar artery. Two vertebral arteries unite to form the basilar artery. Two vertebral arteries unite to form basilar artery, which runs just anterior to the pons in the prepontine cistern. Anterior inferior cerebellar artery, that is also known as ICA, and superior cerebral artery are the branches of the basilar artery, and there are other branches like pontine branches, labyrinthine branch. Two posterior cerebral arteries are the terminal branches of the basilar artery. Posterior inferior cerebellar artery, that is pica, is a branch of vertebral artery. Typical clinical presentation of a hemorrhagic stroke patient presenting in emergency. Patient brought in emergency with history of sudden onset focal neurological deficit like facial nerve deficit, facial asymmetry, numbness, speech problem like slurring of speech, aphasia, weakness of limbs, headache, vomiting, deterioration of conscious level. History of irregular medication of antihypertensive drug is very common. History of smoking and alcoholism should also be taken. The comorbidities like diabetes, ischemic heart disease, and chronic pulmonary disease are also very common. Lobar hematomas may involve cerebral lobes and symptoms depend upon the location of the hematoma and mass effect. Any deep, large hematoma can extend into the ventricle causing intraventricular hemorrhage. Whenever you are seeing a patient with any neurological diagnosis or neurological problem, never ever presume a neurological diagnosis just by seeing the radiology report or just by listening to the patient complaints only or patient relatives version of the symptoms. You must examine the patient without any presumption and bias. You will always feel rewarded. Then listen to the patient and their caregivers. Patient is the best guide and will provide you the important clue to the diagnosis. History taking is an opportunity to interact with people from diversified background. While taking history of a patient who is suspected to have a neurological disorder, take history pertaining to the lesion of brain, spinal cord and peripheral nerves. In this manner, you can complete the entire nervous system. So, if you suspect a lesion of the cerebral hemispheres, history of seizure, headache, vision, and deterioration of conscious level or loss of consciousness, weakness of the face or limbs should be taken into detail. If you suspect a lesion of cerebellum, then history of imbalance, ataxia, and difficulty in walking should always be taken. And if you suspect a lesion of the brainstem, or pons, midbrain, middle oblongata, then the symptoms of multiple cranial nerve deficits like speech abnormality, nystagmus, difficulty in deglutition, loss of gag reflex, and long tract signs like weakness in limbs, hyperreflexia, increased tone in limbs, positive vehemence signs are expected. In patients with lesion of the small cord, history must include detail of the weakness of the limbs, bladder or bowel involvement. History of visual disorder should include onset, frequency, impairment uniocular or in both eyes, partial or total, diplopia, etc. History of loss of consciousness may be due to syncope because of the cardiac causes or vasovagal shock or due to neurological causes like a part of seizure, neurotrauma or space occupying lesion in brain. Loss of consciousness may also be due to low blood sugar level in patients on diabetic treatment or alcohol or drug use. Speech disorder may be difficulty in articulation or expression in understanding. Weakness in the limbs like monoparesis, quadriparesis, paraparesis should be examined. One should begin with systemic examination, see pallor, that is anemia, icterus, lymphadenopathy. Anemia may explain many symptoms. Lymphadenopathy may indicate infection, lymphoma, or metastasis. You must examine the pulse. Bradycardia is an ominous sign of raised intracranial pressure. Irregular pulse may indicate syncope. Blood pressure should also be measured. Hypertension may indicate raised ICP. Respiratory rate, irregular respiration, bradycardia, and hypertension are part of Cushing reflex, which is due to raised ICP. Always note down the pulse rate at the time of initial presentation of the patient. Bradycardia, by measuring, yeah, watching bradycardia, you can save many patients. Bradycardia is indication for early intervention like administration of osmotic diuretic mannitol, or sometimes urgent surgery is required. NCCT scan of brain, that is non-contrast CT scan of brain, is the investigation of choice for diagnosis of hypertensive spontaneous intracranial hemorrhage. Acute hematoma appears hyperdense, that is white as compared to brain. The Hounsfield unit of acute blood on CT scan is about plus 100. Better delineation of acute hemorrhage is seen on CT scan as it appears hyperdense and more white as compared to brain. Non-contrast CT brain is the initial investigation and is also the investigation of choice when hypertensive intracranial hemorrhage is suspected. If hypodensity is seen on non-contrast CT scan of brain, then it is a case of infarct and MRI brain may be advised, which shows hyperintense lesion in diffusion weighted image of MRI. In cases of hemorrhage, there is no need for MRI. But if subrecurrent hemorrhage is suspected, which is evident by hyperdensity in cisterns or in other subrecurrent spaces like anterior hemispheric sphere, interhemispheric fissure, or in interpeduncular cistern or peripontine cistern, or in CSF space of the ciliary fissure, then distal subtraction angiography or DSA or CT angio is advised for evaluation of the intracranial saccular aneurysms. This is for interpretation of intracranial lesions on CT scan. This is the Hounsfield units. Metal appears very white, that is around plus 4000 Hounsfield units. Bone, compact bone is white, hyperdense on CT. Its Hounsfield unit is around plus 1000. Acute blood or hematoma is around plus 100. Brain Hounsfield unit is 30 to 40. CSF is around plus 15. Water is the reference point. It appears black on CT scan and treated as a 0. Fat is minus 100, that is more black as compared to water or CSF. and here is the maximum black, it is the minus 1000. To manage a patient of spontaneous intracranial hematoma, patient should be admitted in intensive care unit, monitor the SpO2, that is oxygen saturation, pulse of the patient because there is a significance of pulse monitoring, bradycardia should be noticed, BP monitoring, IV fluids, Foley's catheterization or external catheterization to be done, osmotic diuretic mannitol or loop diuretic like furosemide, and anti-epileptic drugs to be given, anti-hypermedication to be given. Significant benefit of early operation occurs in patients with superficial lobar hematomas without intraventricular extension. The basal ganglia is the most common site of ICH, presenting 60% of hypertensive ICH, and basal ganglia is associated with 50% mortality rate. Stereotactic and endoscopic surgical procedure may be done to reduce the surgical morbidity. The lobar hemorrhages are evacuated using craniotomy and corticectomy centered around the hematoma with sparing of the eloquent brain tissue. This is the non-contrast CT scan of the patient presenting with spontaneous intracerebral hematoma. In this case, the hematoma is present in the external capsule on the right side. It can be appreciated by seeing the whitish structure on right side. It is very easy to identify because both the cerebral hemispheres are almost mirror image of each other. If some lesion is seen on one side and it is not on the other side, it means there is a pathology. And if there is a history of sudden onset headache with neurological deficit on say left side, then you must suspect there is a lesion in brain on right side. The non-contrast CT shows the hyperdense globular lesion. It is suggestive of intracranial brain hemorrhage. In this case, the non-contrast CT scan shows hyperdensity in the posterior fossa in the cerebellar region, suggestive of spontaneous intracranial hemorrhage. If a patient presents with sudden onset headache, the initial investigation is non-contrast CT scan of the brain. In this case, there is acute blood, that is the whitish hyperdense lesion on right side of the brain in the region of basal ganglia, suggestive of spontaneous intracerebral hematoma due to hypertension. This is the CT scan of the patient where a very small whitish lesion, hyperdense lesion is seen in the thalamic region, suggestive of spontaneous intracerebral hematoma. Non-contrast CT scan of the patient. History of sudden onset weakness on right side plus a small hyperdense lesion in the left side of the brain, indicative of hemorrhagic stroke. This is a non-contrast CT scan of the patient showing hyperdense lesion in the posterior fossa suggestive of brain stem hemorrhage. This is non-contrast CT scan of the patient showing a hyperdense lesion that is hemorrhage in the external capsule region of the brain. This is non-contrast CT scan of the patient showing a small hematoma on the left side of the brain. See the location of a hyperdense hemorrhage on left side of the brain in a patient presenting with weakness of right half of body. Hypertensive hemorrhage on non-contrast CT scan of brain seen on left side. The commonly prescribed antihypertensive drugs are amlodipine, that is a calcium channel blocker. It comes in the form of 5 milligram tablet or 10 milligram tablet. The best thing that you take the history. If any patient is already on antihypertensive drug but he missed the drug, then better to restart the same drug. Otherwise, you can start amlodipine 5 milligram or 10 milligram once a day. Then, if it is not controlled with this, you can start tablet telmisartan. It is an angiotensin receptor blocker. It is around 40 milligram tablet, which can be given once a day. One should not treat hypertension very aggressively, because patient comes in the emergency in a stable condition and you are giving labetalol as an injectable antihypertensive very aggressively. What happens after some time? Patient deteriorates because there is a fall in BP. Therefore, there is no need to over treat the patients. Then labetalol injection can be used in emergency if it is BP is more than say around 220 or 200 millimeter Hg. A labetalol injection can be used in emergency. Other antihypertensive drugs are metoprolol, selective beta blocker, or beta 1 blocker, metoprolol 20 milligram, atenolol 20 milligram, selective beta blocker, hydrochlorothiazide 12.5 25 milligram. Tablet in VAS, that is 5 milligram single dose or BD doses. Enalapril. Side effects: angioedema, cough. Telmisartan has less side effect than enalapril. Tablet arcamin, that is clonidine, start with 0.1 milligram, maximum 0.6 milligram. Tablet comes in 0.5 milligram per day. Indication: it acts on vascular system, not on kidneys. Vasodilation. The common comorbidities associated with stroke are ischemic heart disease, diabetes mellitus, chronic obstructive pulmonary disease, chronic kidney disease. In a clinical setting, cerebral edema is one of the most important causes of raised ICP. If a patient presents with clinical features of raised ICP, then following steps may be helpful. Bed rest reduces the cerebral metabolic rate of oxygen consumption and decreases blood supply. Give oxygenation. Elevate Down elevation of head end of bed 30 degree. Astazolamide, that is Diamox 250 milligram tablet, is a carbonic anhydrase inhibitor and is available in tablet form. It can be given twice or 3 times a day. Furosemide, that comes as a Lasix, it is both tablet and injectable, and 40 milligram or 20 milligram can be given to reduce the cerebral edema. And when it is given, then you should give part chlor or KCl. It may causes potential loss, and management of comorbidity conditions should be done for oral and hyperglycemic or injectable. During admission in ICU, patient may be given insulin on sliding scale. There are different other conditions which may present, like cases of spontaneous intracerebral hematoma. The, the, one differential diagnosis is the subarachnoid hemorrhage due to rupture of the intracranial regions. It is also big bleeding may be due to arteriovenous malformation or other vascular malformations like venous angiomas or cavernous malformations. Many patients of hemophilia or cirrhosis or liver disease present with intracranial bleed. Patients with metastasis, especially with melanomas, may present with the intracranial bleeding. Bleeding may also occur in several intracranial tumors. In certain conditions like dengue, the coagulopathy or deranged bleeding time, clotting time, or deranged prothrombin time, low platelets, etc., may present with the intracranial bleed.